In unplanned urban settings, governments and health systems, they're often not able to deliver health services. Most people have seen lots of images of poor urban areas to realize that this is an issue. Some people would argue that governments are not willing because these residents are very poor and they lack the sort of social political capital to be of interest to the powers that be. Slum dwellers in many cities, including Nairobi, where they form the majority of the population, have had a very difficult time engaging with state authorities in order to improve their situation. The government has not been very responsive to their plight, and that happens even in context where civil society organizations as a whole have played important roles in shaping a national health agenda. Civil society organizations have often stepped in to provide services in slum areas to fill a gap that is left by governments and national health systems. Kenya is an interesting example of a country with a very strong civil society, very active civil society that has played a major role in health, especially in the HIV crisis, yet where civil society organizations from slum areas have not had the same level of access. The Kenyan government had an initially very ambivalent response to the AIDS crisis in the 80s, and they had a poor reputation for corruption and a dictatorial government, and as a result, international development organizations did not fund HIV interventions. So instead, funding was directed to civil society organizations. In 1999, HIV was declared a national disaster, and that opened the door to very large-scale funding of HIV initiatives. The government then set up a National AIDS Control Council to lead a national multi-sectoral approach that would bring together the government, development partners, and civil society organizations. In the National Strategic Plan for AIDS between 2000 and 2005, HIV was also seen as a development issue, not just as a health issue, but really a national development issue and a national disaster. So at that time, HIV prevention and the mitigation of the socio-economic effect became a central part of the international funding. And at that time, lots of funding became available for civil society organizations, including organizations for people living with AIDS or living with HIV, is what we say today. But for people infected with the virus to be enabled to become much more involved themselves in efforts to halt that epidemic. As a result, there were many opportunities to participate in HIV interventions at all levels. And development partners, they focused also on building the capacity of civil societies, partly to counter dictatorial and corrupt state governance, or what they thought was to be ineffective governance. So as a result of this international funding and the focus on civil society instead of government, there was a rather rapid growth of a local economy of NGOs. Most of the funds that these NGOs received went to community-based activities. There were NGOs that were formed by people living with HIV. There were HIV support groups. In the beginning, it was mainly in Nairobi, but people had many opportunities in creating awareness, educating communities, establishing home-based care, fighting stigma and discrimination, and also, because it was a development issue, to press for economic empowerment. So out of many of these organizations, networks were formed, and these networks had access to the national government. Residents in Kibera, which is one of the largest slums in East Africa, they were among the first in all of Africa to receive ARV. They received it through MSF and CDC, not through the national government. And these organizations in turn worked with a network of these local CBOs. So some civil society groups managed to access directly to the national government and they participated in consultations. But the slum residents and their organizations have actually largely been excluded from these national level consultations. They would be more sort of the implementing partners of large NGOs, not policy makers or people who can audit policies. One of the important questions today, with this devolution policy having been put in place, is what the roles might be for representatives of people living with HIV and the civil society organizations that have been shaped and whose capacity has been built. What role can they have in these decentralized counties? It is going to be very interesting to see if devolution could create new spaces for the participation of slum residents. One of the complicating factors is that over 80% of HIV funding in Kenya is from external donors, and at this moment many international non-governmental organizations are withdrawing and their financial support is decreasing. It is not clear where the money for HIV will come from and if and how these local civil society organizations in slum areas will be able to access some of the national funding or the remaining international funding. In Shillong, we're looking at a very different picture. In Shillong, you have a relatively overall rather weak civil society. There's a very few civil society organizations and very few NGOs that are actually engaging with the state on policy. They're certainly not engaging with the state on health. The civil society organizations that are there, they're usually implementing programs that provide services, and they have beneficiaries and clients, including in these slum areas. Although some of the NGOs lobby with the government, they're really quite limited to their ability to secure service provision contracts or to get benefits within the existing policies and programs rather than shaping the policies. One reason for this disengagement is a lack of capacity of most civil society groups to engage in a meaningful way at these different levels, and a lack of an evolved and informed civil society that can engage with the government is a sort of context in which these organizations in slum areas have to grow, develop and operate. And it's quite difficult to imagine how civil organizations in slum areas, especially in the non-notified slum areas, could play a role in policy making on health or policy setting on health. There is an option for poor urban residents to engage in health programs to these village health, sanitation and nutrition committees that have been formally set up by the state and are approved. And this is a system in which citizens would be able to express their priorities or discontents. But unfortunately, there seems to be rather low engagement in the state and not a particular high interest of the members in these local governance institutes to deal with issues related to health or issues related to the health system. So for civil society organizations, it is really not clear what the new urban public health system is or what the old urban public health system is, who the partners are, what the community mechanisms are through which people could speak about healthcare. And because it is so unclear, people are disengaging and they're losing their interest in this formal government process, even when there is an opportunity for greater participation.